for the intro. Mickey and I have been friends for going on 30 years, I think. So
that's right.
It's a long association. I have to say the group, Mended Hearts group that we have at our hospital is a group of wonderful people. They make our job so much easier. They put patients at ease. Just the ability that they have to talk to people, describe what their own personal experiences have been, make it much easier for the patients who are coming in for a procedure, for a surgery, to go through that. I think part of what happens is when a physician speaks to a patient, at a certain point, the patient stops hearing. You know, there's just so much coming at them, and they're in a place where they're worried, they're not, they're fearful, and you don't comprehend everything that's coming at you. And if you have somebody that walks up to you with a sympathetic ear and has had the same experience and is able to sit with you and discuss what you're going to go through, I think it makes a huge difference. And I see the patients who go through that process, their outcomes, their post-operative courses are better. It just facilitates the entire process. So we've missed our Mended Hearts volunteers here during this COVID period, and we're looking forward to getting them back. It just really helps us, and we see them just as an integral part of our heart program. Let's get you back in there quickly, Bill, Mickey. We enjoy having you guys there, and we need you more than you know. So my task was to talk about a couple of the new technologies today. So I'm gonna skip right to that. We will, let me see if I can get this share screen, and here we are. I'm going to start with our talk about aortic stenosis and transcatheter valve replacement. Can everybody see my screen okay? Yes?
I think we're good.
Okay. So aortic stenosis, which is what we're going to talk about, the aortic valve is the valve through which the blood gets pumped out of the heart. And in patients who have aortic stenosis, what happens is this valve, which has 3 flappers on it, tends to start becoming hardened and doesn't open properly. So if you look at this slide, this valve is the aortic valve. And a normal valve looks like a Mercedes sign almost. You see those 3 flappers, that's a closed position. And then right below it is a normal valve with an open position. Now, as this valve deteriorates, and it can deteriorate for various reasons, it gets inflamed. There's sometimes a viral infection, sometimes it's buildup of plaque. But what happens is it starts to have deposition of calcium along the leaflets. And when the accumulation of calcium is minor, you sort of get a mild stenosis. So you can see the valve is now not opening as much as it was previously. And then over a period of time, you know, there's blood pumping through this valve 60 to 80 times a minute, 24 hours a day. And what happens is it begins to wear down and becomes more and more fibrotic and more hardened. And as time goes by, it becomes more and more severe. And this is actually a picture of an actual valve in a patient who had aortic stenosis. And that's what the valve can look like. It can become scarred. It can have all this calcium on it and fibrotic tissue to the point that it doesn't open properly at all. So where normally a valve, a healthy valve is about the size of a quarter, oftentimes when these patients develop symptoms, that valve has gotten down to half the size of a dime. So the heart's pushing against a very tiny opening trying to get blood to the body and the brain and the lungs through this tiny little opening. And what happens as a result of that is that when patients begin to exert, they get chest pain because there's not enough blood getting to the heart muscle itself. They begin to get shortness of breath because the blood begins to back up in the lungs and the lungs begin to fill with water. And they can get lightheaded, they can get dizzy, they can lose consciousness. And that's because there's not enough blood getting to the brain. This also predisposes to abnormal heart rhythms. So these are the classical symptoms of patients who have developed aortic stenosis. And when we hear that these patients have developed symptoms, we know that it's time to do something. So if a patient presents to their physician, to their doctor with any of these complaints, the first thing that happens, of course, is the physician will examine the patient. And what you can hear is you can hear a murmur. And a murmur is just increased blood flow across a narrowed valve. So the simplest way I can explain that is if you had water coming out of a hose and you stuck your thumb across it, that water is going to come out a lot faster. And that's exactly what happens in this valve. That blood starts coming through the valve at a much faster speed. And when you listen to it with your stethoscope, it actually has a whooshing sound to it. And that's what gives you the heart murmur. So these are sort of the things that we look for when we examine a patient. So when we hear that murmur, we go, okay, this is probably an aortic valve that's gone bad. Well, how do we confirm that? We confirm that with a test called an echocardiogram, and that's just an ultrasound of the heart. And what we do with there is we take a little jelly, put it on a microphone, rub it on the chest, and this is what we can see. So in the left-hand panel, you're seeing a valve that is opening and closing normally. We're looking at the valve here sideways, and here we're looking at it end on. This is the diagram that we were showing you earlier. So this is the valve in this view. We're looking at it from above. And this is the valve. We're looking at it from the side. And you can see the flappers are opening and closing nicely. This is a patient on the right-hand side where the valve has become really hardened. And you can see this valve is not opening properly. You see how it's thickened and hardened and calcified. And you can see it over here. You can't really even see the flappers very well. You just see a lot of calcium in the valve itself. And this is the patient that now has what we call severe aortic stenosis. And there are certain measurements that we make with this echo test that tell us whether the valve is severely blocked, is it moderately blocked, is it slightly blocked. But that also allows us to determine what the patient's prognosis is. Because if they've developed symptoms and they have severe aortic stenosis, then their prognosis is not good. In fact, we know that if a patient already has symptoms and we don't do anything, 50% of those patients will actually not be alive 2 years later, right? And in 5 years, 80% of them will not be alive. So this valve diagnosis actually carries a very bad prognosis with it, left untreated. The good news is that if you treat the valve problem, you basically restore the patient's longevity to normal. Okay, so it's imminently treatable. And traditionally, the way this was treated was with open heart surgery. So this diagram shows you 3 different approaches to open heart surgery. There's the open sternotomy procedure. This is where you actually open the chest completely. The patient gets put on a heart-lung bypass machine. They actually stop the heart when they're doing this. They cut the heart open. They actually cut the valve out. They take a cylinder and size the valve. Is it a 25? Is it a 26? And say, oh, it's a 26. Okay, give me a 26 valve. And they take this 26 valve and they sew it into the area where the old valve has been cut out of. They sew it with 25, 30, 40 sutures all along the ring. They then sew the heart back together. They jump started with paddles and slowly wean the patient off the heart-lung machine. So it's a big operation. Now, that was the traditional way of doing it. There are now ways to approach this with a smaller incision, but it still involves stopping the heart. It still involves putting the patient on a heart-lung machine. And it's still a big 3-hour surgery for the patient. It's a wonderful operation in terms of the outcomes are great in 99% of patients, and they do well. And we know that if you operate on these patients and you replace their valves, you actually improve their prognosis significantly. So this is a graph where if you look at the red line, SAVR is surgical aortic valve replacement. If you take patients once they have symptoms and you do not operate on them, you see what happens is the survival of these patients drops dramatically. And out at 10 years, just about nobody is alive. On the other hand, if you operate on them and you replace their valves, the survival curve starts to mimic what a normal person's survival curve would look like, right? So how big of a problem is this? In the United States, there's about 250,000 patients who meet indications for surgical valve replacement every year. That's how many we know need surgical valve replacement. However, only 85,000 of these patients, so less than a third, would actually have surgery. So 2/3 of patients are not having surgery. And why are they not having surgery? Well, the most common reasons are the patients are much older. They're too old to have such a big operation. So to take somebody that's, 85, 86, open the chest, put them on a heart-lung machine, try and get them back off the heart-lung machine, that's a major operation. And as patients get older, they don't tolerate operations that big anymore. You can get them through the surgery, but the recovery becomes a big problem. Because they tend to be frail, because they tend to have heart failure, a lot of them have actually had prior surgery. Some have had a stroke, some have kidney problems, some have lung problems. And this is all a function of just having an aging population of patients. And as people get older, they get medical problems. So they're not the healthy 65-year-old who needs a valve replacement. So we needed another way to approach these patients. And this is where this new technology called transcatheter aortic valve replacement came into play. And what we do here is we basically replace the heart valve through the groin, through a small incision, all built on a catheter system. And when they started out doing these procedures in 2011, the only patients that were being operated on were the ones that were considered prohibitive risk, meaning the surgeons would look at that patient and say, this person is too risky to try and operate on. They're going to die on my table. I am not even going to attempt to operate on this patient. So in 2011, those were the patients that we started to do this procedure on. And what we were able to show is that we were actually able to get great outcomes on these patients, and they recovered quickly. And they did better if you did this procedure versus doing nothing at all. Once we had shown that the sickest and highest risk patients were doing better with this technology, we then started to go to the less sick patients with this technology. So we actually did it in reverse, right? Usually when you start with a new technology, you're looking at doing it for patients that are low risk, and you slowly build up to the high risk. Well, here we went the other way. And we went the other way because we already had a surgical option that was very good for low risk patients. But what has happened over the last 8 years is that with every risk group, we have tested this technology against open heart surgery. And we have shown that this is as good, if not better, in every risk group. So it is less invasive, and you actually have the ability to deliver the valve to a beating heart. How do we go about this? Well, we can go in from different areas. The most common way to approach implanting one of these valves is through the groin. We go through the artery in the groin, we thread our catheters all the way up to the heart, and we deliver the valve inside the heart. In some patients, you have blocked arteries in the legs, or the arteries in the legs are too small and you can't go up that way. So what we're actually doing now is we're using arteries here underneath the collarbone, what's called the subclavian artery. We've even done cases through the carotid artery, which is the main artery in the neck. So when you're working through that, the blood flow to the brain is actually going through one artery, and you're working through this artery going straight down to the heart. In some cases, we are even going straight into the apex of the heart. So we make a small incision between the ribs and go straight into the heart with our catheters. So there's different ways to approach delivering this valve. So what does this valve look like? I'm going to show you a picture of the valve that we use. There's two different valves that are commercially available. This is the one we're using in our hospital. This is the Sapien 3 Edwards Transcatheter Valve. And as you can see, it has a steel frame on it. And in the middle of this steel frame, you see these white flappers. Those are the actual valve leaflets, and those are made from the lining of a cow's heart. At the bottom of the valve, there is a skirt made out of a material that looks almost like Velcro. And what that does is it actually seals the valve into place when we expand it. And this picture here right next to us is the valve after it's implanted within the patient. Right? And how big is this valve? Here's an idea. So this is a normal hand. And you see the valve sitting right there. So it's about the size of a quarter in diameter, maybe slightly larger. That's what it looks like. Now, obviously, when we deliver this valve, it doesn't look like that. What we do is we crimp this valve down so that it is smaller in size. And this is what our delivery systems look like. So we have this large tube, and this is about 45 centimeters long. So, about 18 inches, maybe 15 inches long. It goes in from the groin all the way up to the abdomen. That's the tube through which the valve is inserted. This is the delivery system of the valve. And at the end of the delivery system is a balloon. And that valve is loaded on the balloon. And what we do is we crimp the valve down, and we crimp it. It becomes the size of the catheter. When we get it into position in the heart, what we do is we expand the balloon, and the valve opens like this. And when it opens, it pushes the old valve into the wall of the heart, and the new valve becomes functional immediately. Okay. So this is a little animation of how we deliver the valve. And so we bring the valve, you see how the heart's beating. So what we've done here is we've taken a wire, we put the wire, this is our native valve. This is the valve that's gone bad. And we're going to put our new valve over this valve. We put a wire across this valve, and the wire is actually sitting in the cavity of the heart. We bring our valve up through the leg into the aorta. And this is our crimped valve over here. This is the balloon. And you'll see what we do is we bring the balloon back into the valve that is crimped. We lock that in place. We bring it up and around to the heart. And this is all being done under X-ray guidance. We position the valve where we want it. So we bring it across the old valve, right? And now we know that's in the right place. And what we do over here is we actually have to stop the heart for about 30 seconds. So when you think about it, if the heart's beating and we're trying to deliver a valve, you're never going to be able to position that valve exactly where you want it because it's moving relative to the heart. So what we do is we put a temporary pacemaker in the heart and we speed the heart rate up to 180 to 200 beats a minute. And so the heart, instead of beating like this, it's laying there quivering like that. So it's in standstill basically. But in those 30 seconds, I have to position this valve exactly where I want it, and I have to expand it. So this is what we're doing here. And you watch this, you see the heart beating down here. We've got it positioned now. Now we're going to speed the heart rate up and you'll see it'll start to quiver. We're getting the valve in position exactly where we want it. There's the heart quivering. Valve goes up. Balloon goes down. The valve is implanted and functional immediately, and our catheter comes out. So the actual delivery of the valve takes all of 30 seconds. It takes me about a half hour, 45 minutes to get my equipment in, a half hour, 45 minutes to get my equipment out. And when we do one of these procedures, we do this as a team. The whole cardiac team is in the room. Our cardiac surgeon, who has just been tremendously supportive and helpful in building this program, is in there with his team. I'm in there with my team. And we are prepared for just about any eventuality. If things don't go as planned, we convert to an open procedure. So that's an animation. Here's what the actual procedure looks like. So here's your valve going up, inflating. And you can see the temporary pacemaker down here. Balloon deflated. Catheter comes out. So there's just a running loop now. You can see it. This is an actual patient getting a valve implanted. And this is what the valve looks like on an echo test after it has been implanted. You can actually see the leaflets now. You can see the cylinder of the valve, and you can see the three flappers right in the middle. This is immediately after implant on the operating room table. We're taking these pictures. And this is in a sideways view. You can see the flappers opening and closing over here. And what does the patient have to show for this in terms of an incision or a scar? Well, here's what this looks like. When we go in, we actually deliver two little sutures into the artery first. This is our tube that goes in, and this is about 15 inches long. So it's going all the way up to the patient's abdomen, and that's where our valve goes in. And when this comes out, we just cinch these sutures down, and that's what it looks like. So it's about the size of my fingernail as that incision in the groin. And that's all the patient has to show for it. These patients will stay overnight and they will go home the next day. 90% of our patients are going home the next day. During COVID, we actually sent 7 patients home the same day. And that was done to try and limit their exposure to any risk of infection, because we didn't want to keep them in the hospital longer than we had to. We were done early enough. These patients were done by 9:30 that morning. We watched them for about 7 or 8 hours. They were up and about, walking, eating, going to the bathroom themselves. And we decided to let them go home because we felt it was safe and there was very little risk. So here are some graphics, and these are graphics that basically show mortality in patients that are treated with this therapy and that are not treated. The yellow line is the patients that were treated with this valve, and the blue line is the patients that were not treated. And out at 2 years, you can see that you have decreased their mortality by 25%. That gets to be the case for mortality and stroke combined. When you start to compare surgery and transcatheter valves, you get a 20% risk reduction. And so these trials were done in patients in the high risk, in the intermediate risk, and then eventually even in the low risk trial. And we were able to demonstrate that patients had better outcomes with the transcatheter valves than they did with surgery. So increasingly, that is becoming the default option now for valve replacements. So this is the low risk trial, and even this showed a significant difference, with the outcomes being more favorable with the transcatheter valve replacements. And this is how we classify patients. We actually have a way of scoring their risk. It is based on age, it is based on comorbidities, if they've had high blood pressure, if they've had a previous stroke, if they have kidney problems, if they have a lung issue, all that gets factored in, and the patient is either low, intermediate, or high risk. At this point, just about no one who is high risk is getting done surgically. Almost all those patients are done with a transcatheter valve. Almost all patients that are intermediate risk are being done with transcatheter valves, although some cases are better served with surgery, particularly if they have multiple blockages and they need 3 or 4 bypasses at the same time. So it's very individually tailored on how we make that decision. It's actually a very collaborative process in what we call the heart valve team. And this is the heart valve team, that's me. We've got our cardiac surgeon in there. We've got our anesthesiologist. We've got the referring cardiologists. We've got radiologists that help us do the imaging with the CAT scans. We've got, our valve clinic coordinators that sort of play in to what support system does the patient have at home. If they have an open heart surgery, is that support system adequate for them to recover? Are they better off having a transcatheter valve because maybe they don't need to have a child or a spouse that can look after them at home? So all of these things sort of get factored in, and we try and make the best decision that we can for our patients as a team. And what has happened with this technology is that it has actually extended now our ability to take care of patients that are having other issues as well. So here is an example of a patient who has already had a valve replacement. So this frame that you see over here is a surgical valve that was put in 14 years ago. And over a period of 14 years, the surgical valve has now deteriorated to the point that it needs to be replaced. And you can see this patient has these steel cables that are basically put in when the chest was opened 14 years earlier. The patient actually has a permanent pacemaker in there as well, right? So this is a patient who has already had some major cardiac procedures done, including an open heart surgery to replace his valve. Well, to operate again on this patient, open their chest a second time, to put in another valve creates all kinds of challenges, because now this patient is 14 or 15 years older than they were during their first surgery. And when you operate a second time, you're kind of going through all the scar tissue that's already in there from the first surgery. And you actually have to explant this device that's in there. The old valve has gone bad. You've actually got to chisel it out of the heart and then try and sew a new one in. But what we're actually able to do now with the transcatheter valve is we're able to go in and we're able to implant this valve within the old valve. And the patients get this procedure done all through a tiny groin incision. And you can see there we are, that new valve has now been delivered inside the old valve. So this is a huge plus for a patient that would otherwise have required a second open heart surgery 15 years after their first one. So similarly, sorry, come back to this previous slide. We are being able to provide this similar procedure now for patients who have had a mitral valve replacement. So what we're able to do is take one of these valves, we actually go in from the vein, not the artery, into the right side of the heart. We cross over the interatrial septum, which is a partition that divides the upper chambers of the heart, the left, the right upper chambers. And we actually make a tiny hole through that chamber, through the wall, go into the left side, and we are able to deliver a transcatheter valve into the mitral valve, which has been previously replaced, if that has gone bad now. So this is a picture showing the catheter coming across the septum. This is the valve now being positioned in the mitral position, being expanded. The new valve becomes functional immediately. We remove our catheters. And now the patient has a new valve in the mitral position, instead of having to undergo a second open heart surgery. The next run over here is the actual deployment of a valve in the mitral position. You can see this. There's the deployment. So the heart is sitting here sideways like this. So I'll stop there. This is a quick animation again, just showing you the aortic valve not pumping properly, and how we come in from the groin. Bring our catheters up. Cross the valve with a wire first. And then we use the wire as a rail system. Oftentimes we will actually bring a balloon up and crack the valve if it's really hardened, to make enough room for the new valve to come in. We take the balloon out. And then on that balloon, we load the valve. We bring it back in. So you see the valve is now crimped on the balloon. Bring it up into position. We adjust position. Okay, we're happy with it there. Now we speed the heart rate up to 200 beats a minute. And we expand the valve. And all our equipment comes out. Two little stitches in the groin, and the patient goes to recovery and home the next day. And that's the new valve in place. Sorry, are we still there?
Still here.
Okay.
Thank you.
Any questions?
Yeah, let's open this up to questions at this point, either through the chat room or just wave at Mandy.
I got one in the chat room, and then Ann, I see your hand. So I'll do this and then I'll call on you. Ed, well, Bruce, first of all, says it's the best TAVR presentation he's ever seen. So that's a great compliment. Ed asks, you can do a valve and valve procedure in the mitral position. Are there any catheter solutions for installing a mitral prosthesis in a native mitral valve?
That's a great question. That's actually in the process of being developed. There are clinical trials occurring right now with those new innovations. My expectation is that that'll become commercially available in a matter of 2 or 3 years. They have tried to put in the TAVR valve in a native mitral, but that has not gone very well. Those were patients who had no other options. And in those patients, the success rate has only been about 50%. But these were patients who were going to die from their problem if nothing was done. And part of that has to do with the mitral valve. When it does deteriorate, it is not as calcified as the aortic valve is. So when you expand a valve inside the native mitral, the TAVR valve doesn't lock into place. You actually need a hardened, degenerated valve for the TAVR valve to lock into place. That's really what anchors it when you expand it. So if you don't have calcium and scar tissue and fibrotic tissue into which that steel frame can lock adequately, you don't have a valve that is stable, and that's the problem. So in the mitral, that becomes the issue. So what they've actually done is they're built out a frame that they implant first in the mitral, and then they deliver the TAVR valve into that frame. So it becomes a two-step process. It's all done at the same time, but it's a two-step process instead of just a one-step process. And that frame is actually anchored in the mitral. It is anchored into what we call the chordae tendineae and the pap muscles, which are the supporting structures of the mitral valve that are in the cavity of the heart itself. So this is, it's like a little spiral that gets wrapped around those chordae. It becomes like a cone sitting there, and then they're able to deliver the TAVR valve into that cone, if that makes sense.
You, Ann?
Yes. What about tricuspid valve implants for patients with severe tricuspid regurgitation?
Yeah, that's a great question too. Right now, there are probably at least 9 different new innovations looking at that, trying to solve that problem. We have the ability to use the next device that I'm going to talk about, which is the Mitral Clip. We have the ability to use that in the tricuspid position, although it's not designed for that, so it's an off-label use. It is not a terrific solution. It can work for some patients, but not for every patient. So it's sort of a partial solution, so to speak. The tricuspid replacement prostheses, again, are in development. I suspect we're going to have those within the next 5 years. They'll be commercially available. Some of them are already in clinical trials. But these devices, their journey from benchtop concept to being used in a patient are 5 to 10 years, easy. But it's all coming. It's all happening. And this, I can tell you, for me, this has been one of the most exciting things that's happened in my career. When I became an interventional cardiologist, all I had was a wire and a balloon. I started before there were stents. And we were opening blocked arteries in the heart as an option for patients who were requiring bypass surgery. So our field has evolved to the point now where we're doing the patients the surgeons don't want to do or can't do. It's a complete role reversal, and it has just been a very, very gratifying journey, you know. So
I do have another question in the chat box. Frank asks, does an ICD have to be turned off during TAVR insertion?
yes, because what we're doing is we're actually causing ventricular fibrillation or ventricular flutter. So all we do is we place a magnet over the ICD when we're doing that. That disables the ICD's shock capability. So that way we can actually speed the heart rate up with our temporary pacemaker without having the ICD fire.
Yes, I have a question. This is Lloyd Jeffries.
Yes.
Yes, doctor, I'm turning 78 here this month, and I'm celebrating 5 years with an LVAD. Each year, my MRIs are showing more and more stenosis in my aortic valve, and I'm getting a lot of backflush now, which will put me into a complete loop of my blood. Instead of going out through the aorta, it's going to be flushed right back through the aorta valve back in. Do you, in your recommendations, do you feel that TAVR might be an answer to this as opposed to just sewing shut the valve?
Yeah, that's a decision that would be made with your LVAD team and us, you know, in consultation together. You're a complicated enough patient that every member of your care team should be involved. And a lot of it is dependent on what kind of LVAD you have. A lot of it is dependent upon how much room there is to implant the valve. You know, all those things have to be looked at carefully.
Yeah, thank you. I do understand all that, and that's why I brought it up, is that we have been in conversations about this quite a bit, but I had the option of sometime in the future of sewing it shut, and I'm thinking, I don't know if I want to do that or not.
Yeah, I think without knowing details about your case, I almost can't comment on it. There's a lot of nuance, a lot of detail, information that is necessary to sort of answer those questions accurately. So I don't want to give you incomplete information. But again, I think the best thing you can do is to have your physicians talk to each other and talk with you and explain what their thought process and logic is behind doing behind the recommendation. You know, and I like to say information is empowerment, and if you don't have all the information, you can't make the right decision. So educate yourself as much as you can. There's no questions that's the only question that's a stupid question is the one that wasn't asked.
Okay, and I thank you for your candor. I'm not here to put you on the spot and try to make a recommendation for me, but I heard those were my choices, and I'm getting concerned about the EF and the aortic valve, and I'm not happy with it because I'm starting to get more tired all the time. But yeah, great presentation. I agree with the gentleman that said this is one of the best TAVR presentations we've seen, and it is absolutely outstanding. Thank you.
No worries. All right, I'm going to jump into the mitral clip as well. See if I can click back in here. Okay, can everybody see my screen okay?
Yes.
Yes.
All right, great. So the mitral clip is a solution for a leaking mitral valve. And we're going to talk about this. The mitral valve is the valve that separates the upper and lower chambers of the heart. It is this valve over here. And the common problem with this valve is a valve that leaks. So this actually looks like this when you're looking at it end on. It has two leaflets on it, one large anterior leaflet and a smaller posterior leaflet. So it's just two flaps that open and close when the heart pumps. And when the heart pumps, this valve is closed because it prevents the blood from going backwards into the left atrium and into the lungs, right? So if you look at the incidence of valve disease, mitral valve disease is actually more common even than aortic valve disease as patients get older. It has about twice the incidence. And the leaking valve has a couple of different reasons that it can leak. One is what we call degenerative mitral regurgitation. That is somebody that has an anatomic abnormality that they were potentially even born with. And as they got older, that abnormality becomes worse. The valve begins to degenerate. So you have mitral valve prolapse. And as they get older, the prolapse, the leaflets you can see are not opposing properly, and that apposition becomes less and less, and the valve starts to leak more and more. And then there's a second kind of mitral regurgitation or leak that is called functional mitral regurgitation. And that's where, when the heart enlarges, the valve leaflets start to get pulled apart. And the same thing happens, the blood actually leaks backwards. When these patients come in, they usually come in complaining of shortness of breath, fatigue. And when we see them, you can hear a loud murmur, and that murmur is oftentimes very different than the aortic murmur. This is actually heard more towards the apex of the heart. So it would be below the left nipple, and the sound of the murmur goes into your armpit. And again, we confirm that with echocardiography. And you can, so here's a picture of the leaflets. You can see they're not opposing properly. They're kind of staying one on top of the other. It looks almost like there's a little tear in this one. And when you look at this, this is what the leaflets look like under a three-dimensional transesophageal echo. And this big blue jet that you're seeing here is the leaking valve. You should not be seeing any blue over here at all. So this diagnosis is also made non-invasively with an ultrasound, with an echocardiogram. And sometimes we'll do a transesophageal echo to look at it even better. But what do we know about this problem? What happens with patients who have mitral regurgitation is that they develop progressive heart failure. And what happens with progressive heart failure is, as the valve is leaking, the heart muscle starts to enlarge and the leaflets get pulled apart even further. That increases the leak, and that increases the load and stress on the ventricle, on the heart muscle, and that makes the muscle dilate and become more and more baggy. So you get this vicious circle started, and what happens is you're looking at a patient now who has a mortality of up to 57% within a year of developing symptoms. Well, what are our options? What we know is that left untreated, moderate to severe mitral regurgitation, that's this yellow line, has a really poor prognosis. You can see the mortality lines just keep dropping. And the normal surgery for this is a mitral valve repair or a replacement. And that again is open heart surgery that we talked about before. You open the sternum and you basically end up repairing the valve or replacing it. So there's actually about 4.1 million people that have untreated mitral regurgitation. About 1.7 million of them are eligible for treatment.
Holy
but only about 250,000 are actually getting treated. I should say 250,000 are being diagnosed, but only 30,000 are being treated. So you have this big gap of people that are not being treated at all. And what is the reason for that? The big reason is that most of these patients, or a lot of these patients, are not even good candidates for open heart surgery. They have weakened heart muscles, they're elderly, they have multiple other medical issues, so that makes them very high risk to do a big operation on. Well, this is where a non-invasive therapy like a clip becomes a bridge. So on the one hand, you initially had just medical therapy where you're giving the patient diuretics, trying to keep the fluid off their lungs, trying to keep them functional. On the other hand, you had a big operation. Now, in the middle, we have this option called the mitral clip. And the mitral clip is, this is what it looks like. So it's a little device, it's a beating heart procedure. So the patient is under anesthesia, but it allows us to actually go in, and what we do is we clip the leaflets together, and instead of them now flying open and the valve leaking, the amount of leak is significantly decreased.
The blue flow filling
this
the
is a
left
little
atrium
animation that
illustrates
shows it.
severe mitral regurgitation, or MR. The percutaneous mitral repair system consists of catheters and the Mitral Clip device. The catheter is introduced over a guide wire that has been placed using standard techniques. The dilator is used to gradually advance the guide into the left atrium. The guide wire and dilator are removed. The clip is gradually introduced into the left atrium. The clip is precisely positioned above the leak in the valve. The clip arms are opened in the left atrium for final positioning. Color ultrasound imaging identifies the severe MR illustrated here with blue flow. The clip is advanced into the left ventricle below the valve leaflets. The clip is retracted and closed to hold the leaflets together to reduce MR. If the MR reduction can be further improved, the leaflets are released and the clip re-advanced. Positioning adjustments may be made and the leaflets are grasped again to reduce MR. The double orifice opening allows blood to flow on both sides of the clip. The grasp and MR reduction are assessed before the clip is deployed. The catheters are then removed. Securely attached to both leaflets, the clip moves with the valve, allowing blood to flow through each opening. The mitral valve is repaired without open heart surgery. The Mitral Clip device is made of metal and covered with a polyester fabric to promote healing.
So that's a basic animation of how the clip is delivered. What we know is that with this therapy, we're actually able to decrease the amount of leak. We decrease the hospitalizations for heart failure. We actually improve patients' heart failure status and decrease the size of their heart as well. And the American Heart Association has actually given this a Class 2B indication. So I'm going to go ahead and stop there. Take any questions. I think we're pretty close to running on time here, so hopefully I didn't go too long.
Mandy, do we have any questions in the chat room that we could do a couple of questions?
I don't, oh, yes. what's the instance of mitral clip detachment after the procedure?
That's a known complication. It is rare. I think the incidence is probably somewhere in the 3% to 5% range. It doesn't happen very often. If it does happen, usually it's what we call a single leaflet detachment. So there's no risk of the valve actually breaking loose and going anywhere. And sometimes we are able to go back in and put another clip in if there's enough room there to accommodate another clip.
Thank you. I don't see any other questions, Bill.
Well, Dr. Khanna, I can't tell you how much we appreciate your time here on a Saturday, and your eloquent presentations are always awesome. And I think this is the 4th or 5th time that you've been with us over the years, and we totally appreciate that big time. We also recognize how caring of a doctor you are to the patients at Eisenhower and around the valley here, and you're quite inspirational to all of us. And we thank you so much. Really appreciate it.
Thank you so much. Couldn't do it without your help.
Thanks a lot.